All right, guys. So I'd like to welcome to the show Dr. David Berry. He's a growing voice in the recovery and addiction space, an area that we deal with a ton across EMS and the emergency department. He's been an emergency medicine physician for over 2 decades, and I think this will be a great topic to kind of get into because it's something we all deal with a ton and something we're not always super well versed in either. So if you want to, Dr. Berry, just tell us a little bit about your path into emergency medicine and what drew you to it.
Yeah, sure. I'll be happy to. It's hard to kind of talk about all this without kind of telling my story. So if it gets too long, just cut me off. But as far as emergency medicine goes, honestly, my dad was a heart surgeon, and I thought I was going to be a heart surgeon. And backing up, I wasn't always going to go to med school. Originally, my passion was aviation. I wanted to fly and go that route, and found out I was colorblind and couldn't do it. So ended up switching to medicine, which I thoroughly enjoyed. Thought I was going to be a heart surgeon. I can remember one night, my last year of medical school, I was doing a surgery rotation. And, in surgery, you're on call every other night. So you go to work, you stay for 36 hours, you get 8 hours off, you come back for 36 hours. And it's just like, it's endless. Like, you got to love doing it. And I can remember this one time we were around and had the whole team there. It was probably 11 o'clock at night. I'd been there since way before yesterday. And the chief resident said, okay, let's take a break and we'll meet back at 4 a.m. or something ridiculous. And something about that clicked in my mind that, like, these guys, if I'm going to do this, I'm here all the time. I'm just taking a break every now and then, but I'm not really ever leaving it. And so I thought, well, I'm not sure that's the lifestyle I want. But I like fast pace. I like critical patients, like probably most of your audience. And so it was a quick jump over to emergency medicine.
Yeah, that makes a lot of sense. My surgery rotations in PA school, I was like, I don't think I can stand here for hours and it's like doing one long procedure. I was like, I don't think I could do this either. Yeah, I quickly discovered that wasn't for me. And yeah, the on-call and everything, that's just brutal. We don't have a lot of like great things about emergency medicine schedule-wise, but at least when you leave, you can actually leave. You don't have to be on call most of the time, and depending on the scenario, but you can actually kind of leave work at a certain point, which is nice.
Yeah, I think we take that for granted after we've been in a while because we get used to not being called. 701, don't call me with a pay, that kind of thing. But and it also is. I didn't realize this would be the case, but it allows me to work at more places. If I was a surgeon, I'd have to live within 20 minutes of where I worked or closer. But as an ER doctor, you can be 300 miles, you can be across the country, whatever, as long as which is nice.
Yeah, absolutely. Oops. Let's drop my notes here. Yeah, so I mean, in the ER, we deal with like all types of people. I mean, different socioeconomic levels, all types of emergencies, but we do see a disproportionate amount of people that are dealing with addiction, dealing with mental health struggles. At what point did you realize you wanted to focus more deeply on those topics specifically?
Yeah, so I'll be happy to talk about that. That's kind of the message I want to get out is answering that question specifically for me. So it's going to sound a little off base at first, but I'll bring it back, I promise. When I was born, I was the product of a one night stand. My dad still didn't never know I exist. I don't know if he's alive or not, but he never knew I existed. My mother, it's really a dramatic story. She was being forced by a family member to get an abortion and kind of ran out of the doctor's office or house at the last minute and refused to do it. Put me up for adoption. I was adopted by loving parents, couldn't ask for better parents. But the reason I tell you about the adoption part is when I became old enough and got married, I had my own child, and her name was Haley, a girl. And it was just, for me, I'm sure, it's overwhelming for all parents. And I'm not saying it's more so for me. I'm just saying, for me, I remember looking at her and thinking, this is the first genetically related person I've ever met. And it really kind of I had to sit down. I mean, it kind of swept me off my feet physically. And so anyway, as we all do, we love our children, and I of course loved her. At about 5 months of age, we realized she wasn't moving her legs like she should. And so we took her to the pediatrician. Oddly enough, I had a patient like this about a year before in medical school. And I knew in the back of my mind it wasn't good. I didn't want to believe it, but we got her to the pediatrician. He looked at her, took about 5 minutes, said, "You got to go over to the pediatric neurologist." We drove across town. And the pediatric neurologist told us, yeah, she's got spinal muscular atrophy, the worst kind, type 1, and it's not compatible with life. And so at about 9.5 months of age, she died. We were holding her at our house. It's a long story leading up to that, because that disease is slow and debilitating, and you'd suffocate. It's an awful thing to have to go through. But after that happened, maybe not so slowly, but I began to lean on alcohol to get rid of the pain, lean on it heavily. And I can remember, I grew up in South Louisiana, so drinking's a norm. If you're not drinking at a party, it's, people are asking you what's wrong. So it was kind of hard to tell where that line was. But after we lost Haley, I was drinking by myself to get rid of the pain. I mean, I consciously was telling myself that. And so that went on for about a year. I had some bad things happen. My family started to notice, obviously, and began to say something to me. So because I'm a genius, instead of getting help, I decided I would just switch to opiates. And so I started slowly weaning off the alcohol, so to speak, and started taking opiates more. I liked it. You didn't slur your words. You couldn't smell it on me. I could, do all sorts of things I couldn't if I was just, had a couple belts. And so, and then I remember waking up one morning, and I remember thinking, this is addiction. I couldn't get out of my bed. I couldn't get to the bathroom without a little bit of this opiate. And my drug of choice was Tussianex, which is not on the market anymore. It's a cough syrup, and it's probably straight from hell. I mean, it's got twice as much narcotics as a usual cough syrup. It tastes like a pina colada, and it actually has little bits of coconut in the cough syrup. So it had me all around, and I had this whole elaborate scheme where I was writing prescriptions. I would take patient stickers. I'd write prescriptions. I'd go get them filled. And I had this whole kind of library system set up throughout South Louisiana. Of course, that's not going to last very long. Eventually the train's going to run out of track. And that's what happened to me. I was near the end anyway, mentally, because most of the time I was trying to get off, I was trying to fight the withdrawals, and they just really take it out of you. And eventually the police showed up at my house wanting to know about the prescriptions I was writing, and took me off to jail and spent a night or two in jail. And really kind of was hoping that would be an eye opener. But that's what kind of led me to go to treatment the first time. And I went to the Betty Ford Clinic, and it's a wonderful clinic. It's top of the line as it's touted. And it kind of lived up to that with few exceptions. Unfortunately, I didn't really understand how recovery worked at that point. I thought it was like a pneumonia. You take a course of antibiotics, that's it. You go on with your life. So I thought when I was done, I would be the end of it and I could move on. And that's not how it works. And so I was quickly kind of back in the same boat. And to make a long story short, I went to another couple treatment centers. And eventually my wife left me. My family turned their back on me. They wouldn't have anything to do with me. Of course, I ran out of money pretty quick because the medical board took my license and wouldn't let me practice, and rightly so. And eventually I found myself homeless on the streets of actually Monroe, Louisiana. And I was homeless about a year and a half, I think. And I just kind of, I had these two revelations, not at one moment, but kind of over that period of time. And one was, I was fighting. Anybody that's been on opiates understands the withdrawal process. And that's, it takes you, say, a month to get through the withdrawals. It's miserable, and you can't take anything. And if you get 2 weeks into it and you say, I can't take it anymore, and you take something, you don't get to pick up right there and keep moving on. You got to go back to the beginning and start over. So it's an endless cycle. And so the one thing that I just finally decided was that no matter what happens, no matter how bad it is, no matter if it kills me, I'm just not putting any more of that stuff in my body, and let's see what happens this time. And I also, I was under this overpass, and I remember I had nothing. And it occurred to me I had nothing. I had no wallet. I was thinking about this wallet I'd lost in treatment a year before and wonder where it was. And then I started thinking, well, it doesn't matter. I don't have any money to put in the wallet. And then I thought, I don't have an ID. I mean, if I were to die tonight, nobody would know who I was. They would not know who to call. I was literally, physically, and metaphorically nobody. And that's when I just kind of spiritually reached out and admitted to God that I didn't have any more answers. And if I was going to survive this, he was going to have to do it. And I wish I could say that there was a bright light and the angels started singing, but that didn't happen. But what did happen was, I started getting better. Every day I got a little better, just like the days get a little longer after June 21st. You don't notice it right away, but by September, it's obvious the days are shorter. Well, that's what happened to me, and good things started happening. I stuck to not putting any more of those opiates in my body. It was miserable for a while. There was a point where I really couldn't function. Almost miraculously, I ran into a friend of mine that was a doctor in Vicksburg, Mississippi, and he had interviewed me years before for a job there, and remembered me. And he was in charge of the treatment center there in Vicksburg, and he had studied and learned about this new medicine. It was new at the time, called Suboxone. This was 2005, 2006, somewhere in there. And he highly suggested I try it. For me, it's not for everybody, but for me, it was like a miracle. I could think clearly. I didn't have to worry about the cravings as much. I mean, they were drastically diminished. I could focus on what I needed to do, and it really catapulted my ability to get back to health. There's pretty much two pretty strong schools of thought about that, and I respect both sides. I don't think we should start aerial spraying with Suboxone, but it's a tool that should be in our toolkit for those of us with opiate use disorder. So anyway, after that, my friend Randy, who had seen me and suggested this, he actually almost within a few days got appointed to the medical board in Mississippi. And he said, Dave, if you want your license back, it'll take a little while, but I think I can help you. And at the time, I'd never even considered. I thought that was over. I thought, I've been arrested. They've taken my license. That part of my life is done. I'll never practice again. I even started studying for the LSAT and kind of things to move on with my life. And so when he said that, it was really like the first glimmer of hope I had. And sure enough, it took about 3 or 4 years, and he had to convince a few people that didn't know about the medication. And I had to prove myself officially through the physician monitoring program. But eventually in 2010, I was awarded an unrestricted license in Mississippi. And I've since actually got a second license in Colorado for a treatment center that started. We can talk about that a little bit. But then after I got that, of course, I wanted to get back into emergency medicine. I started picking up, extra shifts that I could find here and there, prove myself a little bit. The more I proved myself, the better, the more people trusted me and my reputation kind of built. And so eventually I was asked to be director of emergency medicine at a hospital just outside of Oxford, Mississippi. And I'm saying all this, anybody that's been in emergency medicine knows that's not really necessarily something to brag about. I mean, it's administrative position. You don't really have any power. It's kind of a pain in the butt. But for me, it was a mile marker, And so after I'd been at this hospital for about 4 years, a CEO from another hospital kind kind of the next town over, approached me, and I thought I would never leave where I was, but he made me, as the Godfather says, he made me an offer I couldn't refuse. It was fantastic. And so I joined this new group, and I was immediately brought on as the director there. And then 2008, that was in 2016, 2018, I was elected chief of staff, which again, that's kind of something we all rotate. It's not a huge accomplishment, but for me to go from, homeless to chief of staff of the hospital was really something for me to reflect on. And anyway, that's kind of my story back in emergency medicine. And then the CEO who brought me to this hospital wasn't in recovery himself, but he had family members in recovery and had an interest in it. And so, I approached him one day and suggested that we team up. And we did. We put together a good business plan, raised the capital. It started our own drug and alcohol treatment center out in Western Colorado, and we ran that for about 3 years. That's where I got why I got my Colorado medical license. And the reason I mention that it's when we get into regulatory issues, it's interesting, the dichotomy between what I went through in Mississippi and what I went through in Colorado. And it just shows that there's not a whole lot of standard there, and by extension, I feel like there's not a lot of standard in mental health, as a whole, compared with internal medicine, surgery, all those other fields. So we did that. We've since sold the center to a bigger group that can expand it further, and it's still out there kicking along. But that's kind of my story. That's what I went through, and why addiction medicine is so important to me. I've just kind of, ever since I came out from under the overpass, so to speak, I've tried to acquire as much knowledge as I could and focus on those type of patients whenever able to.
Wow, that's an incredible story. I mean, I think that has to give you a whole frame of reference and empathy dealing with these addicted patients, which I think is something that we all kind of struggle with. But I've felt that before. Like, when you look at these patients, they're not that many far steps removed from where I am. I mean, dealing with the loss of a child, I can't even fathom what that does to you. I mean, if I think about losing, my girls, I would not be a lot of steps removed from being homeless, and none of us really are. It's a couple mistakes and you're homeless. And I think understanding that these people are not so far removed from us. They've made a few mistakes. They've dealt with hardship. And if any of us dealt with that kind of hardship, like the loss of a child, I mean, I can't even fathom what that would do to me. I mean, it helps you relate to those patients on a level that I think is super important to actually help them, and set up these protocols and procedures to get patients on Suboxone and a treatment pathway to actually get them help, which so many of our hospitals don't have the infrastructure to do. And it's a horrible missed opportunity, I think. Because we see these people, we see them when they accidentally overdose or when they intentionally overdose, and often we have no great steps to help them in the future from that. So that's an incredible story. I mean, going all the way to homeless, living under a bridge, all the way back to chief of staff. I mean, that is incredible.
No, I sure have a different appreciation for life, and I've since got remarried to my best friend, and have 2 boys. So it's a real gift to be able to look at them like that,
That's amazing. Yeah, that's an incredible story.
Thanks. But you're right about dealing with patients in the ER with similar problems. A lot of times we see them as frequent flyers. And I feel I even catch myself when I'm busy kind of blowing them off, or not blowing them off, but being frustrated with them. And I feel very guilty about that, because somebody took the time to help me. I should do the same for them. And here's the other thing. A lot of those patients we created, sickle cell patients. We load them up on morphine every week. Well, what do we expect is going to happen? You know, and you know, in the 90s, it was a big deal. You know, doctors were scared not to write a prescription for Lortab because they thought they'd get sued. And so a lot of those patients are the way they are in part because of the way we approached this early on. So the empathy has to be there, I feel like, and taking the time. You know, we may not have a lot of time in the emergency room with patients, but what I found is I found little ways that I can appear to be taking more time with patients, even though if you looked at a clock, it might not be a lot of time. And that can make a difference in a lot of ways because maybe you hear something you wouldn't have heard otherwise, you know?
What are some of those techniques you use? Because I feel like I have some of those as well. Like we are up against the clock most of the time. We don't have a half hour to sit at a patient's bedside. But what are some of those techniques you use to kind of use your time really efficiently with them and get them to open up? So,
you know, one of the things I've learned actually I did some rotations at the Mayo Clinic, and they're all fabulous. But this one doctor that was there, he didn't even know he's teaching me this, and it sounds silly because we should do it all the time. But I remember he would say now this guy's a world-class cardiologist. I mean, nobody should be speaking in his presence, but when he goes and talks to a patient, he asks him, he said, after he gets the HPI, he says, "Do you mind if I examine you?" And you think that's kind of silly, but what it does is it gives the patient some control. They're in this terrified situation a lot of times, and here's the doctor asking if it's okay, rather than what I usually do, just shove that stethoscope in their face and start listening and don't give them a choice in the matter. That is, for me, as simple as that seems, has brought about a lot of help in relating and connecting with the patient. The other thing I do, which I was taught in med school, I'm sure you were too, I always touch the patient. I remember I had a professor that always touch the patient. So either, you got to read them. Of course, not everybody wants to be touched, but I'll try to put my hand on their shoulder, or if we're having a serious conversation, if I can, put my hand on their hand, hold their hand or put it on their arm or something, it gives a sense that you're slowed down and completely focused on them, or at least I hope that's what it does.
No, I love that, giving the patient a little bit more autonomy in a department where they're kind of rushed through and they're getting taken to imaging and they're getting IV, and maybe the tech doesn't even ask them for permission. They just throw the IV in them. And I love that. Like, hey, is it okay if I examine you real quick? I mean, that's just a small thing, but it gives them that autonomy and a little bit of control. I love that.
Yeah.
What do you think are the biggest misconceptions that we have as emergency medicine clinicians about these patients?
Yeah, I think you did a great job of hitting the nail on the head. I think our biggest misconceptions are they're trying to game the system, and maybe some of them are because they have no other options. But we leave the thought there. They're trying to game the system, therefore they equal bad, and we need to fight against that. When the reality is that even if they are gaming the system, they're probably doing it because they've run out of other options. And I need to kind of focus on that, remember that, and try to empathize with where they might be coming from. Why are they here? What's their, we don't do much social history or in the ER, but to try to kind of assess a little bit of their background and what's causing these things. The other thing that I've found helpful for me personally is we have a couple of frequent flyers that come into my ER that, once a week, they're there sometimes 3 or 4 times a week. And one of them is really frustrating. And I remember I said one day, I said, you know what? I'd left the room. I said, same complaint, same thing. I said, you know what? I'm going to go down in there and sit with her and ask her how I can help her. And so, I went back in there. I sat down with her. I said, look, I want to help you. What can I do to help you? I don't want to make the problem worse. I can't give you narcotics. That's not going to be good for you. And I don't want to be a part of worsening the problem. But what can we do to help? And, sometimes nothing really comes of it, I guess. But it does allow them to start the line of communication and understand that there may be some concern there on the part of the medical staff.
I think, yeah, and I think those small conversations can be, I mean, it's that behavioral change kind of continuum, right? Like maybe they're on the fence, maybe they haven't even considered there's a problem, but if you can kind of bump them into that next step, maybe further down the line, the next provider will actually have a little bit of a window to say, hey, let's start getting you off of these narcotics. Let's get you on to something else. And you kind of move them in that direction. And they talk about that with like smoking cessation, you know, like if you can just put it in their mind, maybe this is a problem. And then the next provider can say, we need to get you off. And eventually they're on the fence and they're debating a change, and the next provider can get them off smoking completely. I think that's a small thing that we all need to do better to kind of start moving them towards that behavioral change, because it has to be their initiative, right? I mean, we can't force it on anybody. It's got to be their idea, but if we can kind of move them down that path, even in just a small way, by taking that extra minute to have a conversation, I think that is a small thing that so many of us ignore, you know, in the busyness of our day.
Yeah, I'll tell you another area where I see this bias, not to deflect from my profession, but in the pharmacy, man, if you got a prescription for a controlled substance, it's like they treat you like you're lower than life. And I don't know where that comes from. I mean, they're not the ones prescribing it. They're not the ones treating the problem. They just fill in the medicine. But a lot of times I see them really, being unprofessional in the way they handle somebody with a controlled substance prescription. And I wonder if they could, like we're talking about, have a little more empathy, how far that would go.
Yeah, and I think the pharmacists don't even see what we're prescribing them for a lot of times. They're seeing the prescription. It's like, well, they have a kidney stone. They're going to be in pain for potentially a few days. They need something so they can pass this at home, or they have a broken bone. I mean, there's a ton of legitimate reasons why we prescribe them. But even now, I mean, I've only been practicing for 5-6 years. I'm so nervous about prescribing more than 8 Norcos because of the environment. And it's like, I'm hoping these 8 Norcos are going to get these patients to a specialist when they have a legitimately painful condition that's debilitating and they need to be on something strong. I mean, there's legitimately painful things and legitimate reasons for them, but I feel like the pendulum's kind of swung, and now we're super nervous about overprescribing these, and for good reason, right? I mean, we created this problem and now we're trying to fix the problem, so we're very hesitant to give them too much. But you're right. I mean, there's this stigma now, and the pharmacists probably aren't really understanding what it's for a lot of times, and they actually need this medicine. And they shouldn't be made to feel guilty because they need help with pain control.
And the bottom line is they're still patients, even if they're drug seeking and they're drug addicts, they're still patients, and we shouldn't shirk our responsibility to tease out what the diagnosis is and go after it. And I feel like maybe I could always do better in that area.
Do you have any guidelines for how you diagnose someone with opiate use disorder or anything in the ER? Do you use that code a lot to try to move them down that path to understanding that they have an issue with it or an addiction to it? Or do you kind of avoid that code of labeling them with like opiate use disorder?
Yeah, that's a good question. So I probably lean towards not labeling them, just because I feel like, it's kind of like putting anxiety disorder on the diagnosis. Somebody else somewhere else will see that, and then they'll be labeled with that forever, and so I don't feel like I have enough time. I don't see them regularly enough to administer that diagnosis to them. Certainly that doesn't mean I can't talk to them about the issue and kind of encourage them and try to see if we can't get them some help. But and we have a fantastic clinic at our hospital. It's open 7 days a week. I think it only closes on Christmas and New Year's. So those guys are really good at kind of picking up the ball and doing the things you're talking about.
Yeah, I think that's how a lot of our providers feel too. It's maybe not great to put that label, just like anxiety. You know, they're anxious today. That doesn't mean they have an anxiety disorder. We really don't have enough time with these patients to probably be labeling them with something like that. And yeah, and then the bias that passes on to other people. You see opiate use disorder in their history, and you're more likely to assume the abdominal pain they're here for is going to be nothing, you know. And often it is, but that doesn't mean they're not having pain, you know.
Yeah. I had it's funny you should say, I had an attending. He was the director of our emergency medicine program in Louisiana. And he was one of the smartest guys I've ever met. And he graduated first in his class, and he more than that, he just loved emergency medicine. He loved medicine. I remember he'd go on trips and he'd pack a whole roll around bag with nothing but medical journals. Shows you how far back it goes. He was using, real paper medical journals. But he said he loved nothing more than sitting on the beach and reading medical journals. So this guy knew everything, it seemed like. And he would always tell me, Dave, don't try to guess whether the patient is hurting somewhere. If they say they're hurting in their belly, they're hurting in their belly. Don't play this emotional game of, well, they're just here all the time and it's not real. If that's what they say, that's what's on the chart, that's what they have. And then he would also say, if somebody's hurting somewhere, you want to image that spot. So one way or another, you want to image that spot. And so I try to remember that, especially at 3 a.m. when these frequent flyers come in. They're telling me they got belly pain for the 6th time. I'm going to get that CAT scan. And sure enough, within the last couple of years, I've had a couple of frequent flyers. One had a small bowel obstruction, and another one had some other surgical abnormality that, if we'd have blown them off, they'd probably be dead, But you got to go through that process, or at least I do. Others may be good enough to diagnose them without that.
Yeah, I mean, that's a common one. I mean, I think anybody listening probably pictures patients in their minds when you talk about it. They're like, oh, this is just like so-and-so we see all the time.